for us to do this ultrasound training and followed by the synovectomy for the patients. So thank you very much for your attendance here, because it's a history for me and for the WFH team that you are the first participant in this historic training that we are doing now at the Federation. And I would like to take this opportunity to thank our partners, our volunteers from the University of San Diego and the University of from the Hospital of LAOH, Los Angeles.
We are doing this. You're most welcome to this facility. And I know we will learn a lot. Most of us, probably it happened during the training programs. And now we are meeting with these again. Spinal injury, you will rarely meet the hemophilians. I don't know, probably Masinda may have as a physiotherapist. In the West, it's mostly trauma. So you're most welcome. I am the chief nurse of this hospital. They call me the mother of the hospital.
Because you will see how easy it is. Echoes reflected by tissue structures can create an image. And here you have the anatomical image. You will recognize it: suprapatellar bursa, femur, blue is cartilage, tibia, and this is the suprapatellar bursa that fills up with bleed if there is a bleed. Here are the recesses. We can see it because it's just unidimensional, and that's the joint space. And can you see how anatomic this ultrasound picture here is? So you have the quadriceps tendon going into the patella. You have a little bit of fluid, just this is my knee, just a little bit, probably 1 or 2 milliliters, that's all there is. And that is separated from the cartilage, who is also black, because cartilage is mostly water, by that interface line, and the femoral condyle. So look at that. It's easy, right? Everyone can learn this. So for hemophilia, what do we do with point of care ultrasound? In our practice, mostly for the etiology of joint and muscle pains. That's how it will help you most. Is there just an effusion? Yes, no. Is there a joint or muscle bleed? And we will have a little look how to distinguish the two. Yes, no. Is there hypervascularity, i.e. inflammation, which might help the physical therapists to decide a little bit on what to do with that joint after bleeding? Yes, no. Is there a tendon sprain? Once you get more experience in your exam, you will get advanced use. You can say, and other things. Your physical therapists will explain that to you. Then what we will learn most right now is guidance for intra-articular needle placement, for aspirations, if you catch someone early with an acute bleed, or injections such as steroids, or now we do the chemical synovectomy. And you see me here, the big ultrasound machine to help with needle guidance. We don't need that anymore. That was 10 years ago. Now we do it with handheld machines. And then we have long-term follow-up options for joint findings, but that's less of a topic today. Other than using a certain protocol, it's called Jake protocol, as we will learn later, to measure the success of chemical synovectomy by measuring out the synovium and sentinel positions afterwards. So now,
If you could go back to the previous one, when you talk about hypervascularity, are you talking about the hypervascularity in the synovial membrane? Okay.
In the synovial membrane, because the synovial swells up in hemophilic arthropathy and it gets very vascular, and the extent of which we can see with the power Doppler, we will see in a moment on the ultrasound. So now that the stage is set, we have learned about ultrasound, we'll talk about hemophilic arthropathy. As you all know, and please everyone just raise your hand, ask questions. Cindy, Peter, Bruno, if you want to contribute, interrupt me. Unavoidable, despite all best prophylaxis, because everyone will experience breakthrough bleeds, and I'm sure our hemophilia patients can confirm that, and so often results in a debilitating condition at young ages. So the pathobiology behind it, I think we can all agree, or it's most commonly accepted, that iron that's released by the red cells into the joint space is the incendiary and starts it all. So once that bleeding occurs, there will be through iron, which is fairly toxic. There will be synovial hypertrophy. And please keep that in mind, because this is where the vascularity comes in. There's lots of new vascularity, vascular remodeling. Think about it like a real vascular tumor. These vessels are fragile, so they will break despite prophylaxis or correction of coagulation. And then it comes to frequent bleeding, and that causes cartilage destruction and joint destruction. So iron is the incendiary, so we have to prevent bleeding, and this is probably why it's good. If you catch someone early and you have blood in the joint, and now you have needles and an ultrasound, get the blood out. The less iron, the better.
So now with your left hand this way, it's going to be like how you started aiming for, yeah, that, right? Something like that. Move it in. Yes.
Yeah. Okay, you see that. So here's